Our concluding speaker for our morning session, actually we have two speakers that will jointly speak to us. Dr. Richard Gregoire was educated at the State University of New York at Buffalo in the School of Medicine, did his internship and residency at the University of Utah Department of Family and Preventive Medicine, is currently the medical director of the Midtown Community Health Center and the Health Clinics of Utah here in Ogden. So we welcome him, and also speaking with him, Dr. Harry Rosado-Santos, who received his MD in the University of Puerto Rico, did his residency and fellowship training as a fellow in infectious diseases at the University of Utah School of Medicine, and is currently an associate professor of medicine and the director of the fellowship program in infectious disease at the University of Utah. And they will speak to us on, I think, the current aspects of HIV. Ah, there we are. Doctor, there's only one of you. Is the second one of you here?
I hope he is.
Okay.
I got a call from him a few moments ago about where this talk was being given, and he was headed to Ogden Regional Hospital. So we'll see how this goes. Well, thank you very much. We're essentially going to go from one natural disaster to another, from Katrina to the HIV/AIDS epidemic. Then I understand we're going to talk, or John Berry will talk at noon about the 1918 flu pandemic. So I hope somewhere in the course of this couple-day conference that there's some good news to be had. Not much this morning so far. The care of HIV and AIDS, I think, lends itself well to the theme of this year's conference, which is the integration of care of primary care physicians and specialists. Dr. Rosado, hopefully, and I will share this hour in discussing various aspects of HIV care. My presentation being somewhat broad, and his will focus on certain specific issues that are not only common to doctors that are treating HIV patients per se, but also in the day-to-day practices of others as well. This is the obligatory financial disclosure. The other disclaimer I have is that I am not an HIV specialist. I've been caring for HIV-infected individuals for 10 years or so, along with Dr. Kurt Reiffelman at the Midtown Community Health Center, which is located only a few blocks from here, and I'll introduce you to that, to our Community Health Center as we go along here. Before quickly narrowing the focus to HIV care here in Utah, and specifically here in northern Utah and Ogden, I wanted to remind you of the incredible scope of the epidemic worldwide. These are some impressive numbers, and I apologize. I'm going to have to refer to some of my paper notes because I have to have a redo of my LASIK surgery, which was done about 8 years ago. But in any case, there are about 33 million people. This is 2007 data. About 33 million people living worldwide with the HIV or AIDS. Approximately 2 million of those being children. New infections annually numbering about 2.5 million. And deaths numbering greater than 2 million, and those numbers are probably increased in 2008 data. The distribution across the globe is, as you know, very uneven. The vast majority of HIV and AIDS confined, I shouldn't say confined, but prevalent to the sub-Saharan African region, of course. Only about 4% of total infections worldwide are found in North America. This holds true, of course, for new infections. That is the relative proportions in various areas. In the United States and Canada, I believe there's between typically 40 and 50 new infections annually. So I'll turn now to the tiny fraction of these infections that we find in Utah. And what I won't do is try to rush through a detailed review of the relevant history and physical exam, lab workup, and management of an infected patient. I don't think time allows for that. Care has grown very complex, particularly over the last 10 years or so. Just as an example, there's over 30 or so antiretroviral drugs in 5 different classes, combinations of various classes in terms of approach to management. So I don't think time is well spent trying to rush through those cataloging of various guidelines. What I will do is give you a couple of references at the end of the end of my portion of the talk. And you can, if you're interested in examining those guidelines, which come out about every 2 years because care is evolving so rapidly, then you can refer to those at your leisure. Instead, I'll take a broader view and leave you with an understanding of the history of primary care for individuals in Utah. Define our role here locally at Midtown Community Health Center in terms of providing care, spelling out a bit of the criteria that primary care physicians like myself use in terms of referring patients to specialist care, and then identifying resources that we as primary care physicians use in terms of optimizing our care for these patients, but also resources that infected patients can use to improve management of their disease. This doesn't project very well, but this slide shows you that in Utah, since records have been kept in the early 80s, approximately 25 years worth of data, that there have been about 3,400 infections. Probably about 3,500 by now, as we have about 130 or 150 or so a year. The great majority of these infections being along the Wasatch Front, about 90% of these infections along the Wasatch Front, 70% of the total number of infections being in Salt Lake County alone. The majority of patients outlying in rural areas still do come to Salt Lake City, specifically Clinic 1A at the University of Utah for their HIV care needs. As you can see, well, maybe as you can't see, Weber and Morgan counties do have their fair share of infections. There has been, this slide demonstrates cases by year, and you can see a peak incidence occurring in about year 2002 with subsequent, I'm sorry, in 1993, there go my eyes again, and thankfully, let me see if I can work this. Thankfully, a steady decline in number of infections once the introduction of highly active antiretroviral therapy was introduced in approximately 1996. You see a steady decline of number of infections in the state. A little bit disturbingly is the subtle increase in numbers of infections annually since about 2002. You can see also the effect of antiretroviral therapy on the total number of deaths in the state that has really gradually and very steadily taken deaths, that is in the dark navy blue, down to very minimal numbers by now. And this is a credit to I think the management in the state of following up-to-date care, that deaths have been reduced. You do see similar trends, nationally, but it was about somewhere about the mid-90s where, with the introduction of heart therapy, that HIV/AIDS became more of a complex chronic disease to manage rather than an automatic death sentence, which it had been prior. So where are these patients, or who are these patients in Utah? We see a strong male to female predominance in terms of gender, about 8 males for every 2 females. A young age, greater than 70% of infected individuals to date being less than age 50. Being a quite homogeneous Caucasian state, obviously a white race predominance, but a disproportionate representation of people of color, Hispanics and blacks, relative to their proportions in the state. I think we have about 10% Hispanics in the state and about 1% Afro-Americans. So those populations are disproportionately represented. In terms of exposure risk, I go to the next slide. Males, far and away, they're the greatest exposure risk for transmission of infection and infection themselves is men who have sex with men, or MSM, followed by injection drug use. If a certain individual has both those risk factors, we see a trend over the last couple of years of increasing risk and transmission risk for others in that setting. Amongst females, certainly the heterosexual contact from infected partners is most predominant, followed by injection drug use in females. Where is care provided? There are a small number of community primary care physicians made up of internists, family docs, infectious disease specialists in private practices in Utah that do manage a small number of HIV patients. Historically, the greatest amount of care has been obtained at the University of Utah Infectious Disease Clinic 1A, where Dr. Harry Rosado is a mainstay. His workload has likely increased. Dr. Kristen Reese, who has really directed that clinic for many years, has been trying to retire for a couple of years, somewhat unsuccessfully. But the infectious diseases department at the U is the largest federal grantee of Orion White monies. And those are monies that are directed for patients that can't afford private insurance, and to cover them sufficiently in terms of their needs for HIV care. The U had set up a primary care alliance, or a PCA, and this is how we became involved at Midtown Community Health Center in HIV care. The primary care alliance is the intent was to find outlying clinics so patients in areas away from Salt Lake City would not have to travel so far to get to their visits. And of course, if there are no showing for visits at Clinic 1A, there's danger not only to themselves in terms of morbidity, mortality risk, but also in terms of transmission of infection to others in their community if they're not properly treated. So the Primary Care Alliance was an effort, or is an effort, to identify community physicians willing to see HIV-infected individuals in their practices so those patients can be seen more dependably in their own locales. We got involved with this care in 1998, hearing that a lot of individuals from northern Utah were not making the trip to Clinic 1A dependably to get their care. We started, back in 98, we were housed in a very modest, to say the least, clinic on 28th and Madison, right here in downtown. And we quickly have outgrown that clinic, and thanks to the donations and generosity of many in the community, actually many sitting here in this room, I think, we were able to fund a brand spanking new clinic about 3 years ago, which has really afforded us the ability to expand our services, be much more comprehensive in terms of our services, and provide better care for HIV individuals and many others alike, actually. And this is only a few blocks away. We, in the 3 years we've been in the new facility, have pretty well reached capacity and have recently purchased an acre of land next door on the south side to further expand, and we probably will add another dozen exam rooms in the next 2 years or so. So keep being generous, please. We have grown tremendously over the last several years in terms of number of service sites. We have now 2 medical clinics, our main clinic here in Ogden, of course, and opened up a community health center in Davis County as well, currently housed in Farmington. And we will be moving that clinic to Clearfield in conjunction with the Davis County Health Department within a year's time. So that will then be located in Clearfield. In addition, we have dental clinics affiliated with both our Weber and Davis medical clinics. The one here in Weber is associated with is a partnership basically with the dental hygiene program at Weber State. More recently, we have acquired, I shouldn't say acquired, but partnered and have a children's clinic in South Ogden under the direction of Dr. Margaret Cluthy. And we've opened up a school-based health center locally at James Madison in the last few months. So we've really grown in terms of our capacity to see more patients. This growth is reflected in the fact that about 10 years ago, we had about 6,000 patients within our system. Now we have about 26,000. You can see, even with that growth, our demographics have remained about the same. Some of you may think those are pretty dismal-looking demographics, but about 68% of our folks being uninsured, about half non-English speaking, very low income being defined as less than 200% poverty level, and plenty of children to go around as well. Our services are broad, and again, I think the comprehensive nature of services is very important in terms of providing care around the issues of HIV care, specifically mental health needs. A lot of our HIV population are quite, broken down and out people that have used injectable drugs for many years, have an array of mental health issues, and we've really beefed up our capacity to see these patients. This improvement in our mental health coverage also grew out of the fact that the county mental health system was unable at a point a couple of years ago to see uninsured patients. So not by choice, but we inherited and tried to respond to the needs of the community of patients, many of whom included, or many of which were HIV-infected individuals. We also do a bit of hepatitis C treatment. As you'll see in the next slide, we do have several patients that are co-infected with HIV infection and hepatitis C. This management can get quite tricky, and thankfully I have people like Dr. Rosado to fall back on when things get a little bit too much beyond the scope of primary care. Now remember the 33 million worldwide infected individuals that we showed you. This is the 33 of them that we manage at Midtown Community Health Center. So we're very small in terms of our contribution to the worldwide plight of HIV/AIDS, but this is what we manage. So the targets, of course, are complete viral load suppression of HIV virus, and you can see the great majority of our patients managed here, except for purposes of referral, have undetectable viral loads of less than 48 viral particles per ml. And the other goal of therapy, of course, is to maximize CD4 counts, which is a reflection of an improved immunity, improved immune system in response to highly active antiretroviral therapy. The great majority of our patients are on combination therapy. You see that a triplet, for example, is listed as a single drug regimen, but actually that is a triple regimen in one combination pill. So the ease of dosing and the convenience of care has grown tremendously over the last 10, 12 years. So although the treatment, I think in terms of staying on top of the management of HIV AIDS patients has grown a bit more complex for physicians, I think in terms of patient ease and management of their disease, it has grown easier for patients. This is demographic data, just comparing the patients we manage here in Ogden to statewide data. And you see that we have here managing patients in Ogden that are more significant in terms of percent female relative to the overall state population. Probably most striking is the, oops, how do I go back here? Sorry about that. Probably most striking is the differential in age of the patients we see up here. You know, as you combine these percentages, greater than 70% of our patients at our Ogden site are over age 40, whereas greater than 70% of the patients statewide are under age 40. I don't think that reflects our superior care relative to other practitioners in the state. As I kind of reviewed this slide and was scratching my head as to why, I think the state data reflects is cumulative data. That is data obtained pre-heart era and post-heart era. And of course, you know, when young infected patients were dying in their 20s and 30s, that certainly was skewing numbers. But the fact is that, I guess the point to be taken is that HIV/AIDS patients are living longer, which presents, you know, a greater number of patients to be shared, hopefully by all of us, and that the comorbidities that these patients bring to us are greater and greater as time goes on. In terms of race, as we would expect, in Central Ogden, we see a large Hispanic component relative to statewide numbers. Afro-American numbers remain the same, state versus Ogden, but again, disproportionately high in the minority populations in terms of representation with HIV. Exposure risk, as you would expect with a higher female cohort, heterosexual transmission risk is higher in our group than it is statewide, and MSM is lower. This slide just reviews, basically lists the primary care services we offer at Midtown for our HIV infected patients, and really reads down like a guideline would suggest in terms of comprehensive care. And our ability to provide this care has grown significantly with our move and with the addition of mental health providers. A couple points to be made in terms of the initiation of antiretroviral therapy. There certainly is a trend to move towards earlier therapy, and this is shown to be important in terms of lower morbidity and greater longevity. That is, start patients with CD4 counts greater than 350. We used to wait until they were less than, or actually even towards 200 CD4 cells. But following guidelines in terms of that care and other care is something we take to heart and do. We also provide full immunizations, mental health counseling, dental services, and appropriate referral and coordination of services. One thing we do offer, you may have seen on the other slide, are enabling services in terms of health access team, which is part of our clinic that provides resources for case management for individuals that have a hard time managing their own affairs and getting to appointments and that sort of thing. As primary care physicians, Dr. Rifleman and myself probably have a pretty low threshold for referral, although the data would suggest those of us in primary care that are managing HIV, the more patients we're experienced with, the less we likely will refer to specialists. I tried in putting this talk together to find documented criteria of when it is proper to refer to an HIV specialist. That literature is just not there. So I kind of winged it and made up our own, and pretty much this is kind of the gestalt that we use at Midtown for referral. We realize we're not HIV specialists, that we have specialists and experts that have been dealing with this for much longer than we have, 30 miles south of us, and basically if we have doubts about reaching our maximum, then we will refer. Common scenarios for referral are listed there. Probably most often treatment failures on initial regimens designed to suppress the virus are most common reason for referral, but there are many others. But I would say, probably we were managing fully 90% of patients 90% of the time. So it can be done. This is probably the most valuable slide for all of you in terms of a take-home. This is a list of various resources that you can call on. I'd like to draw attention particularly to the HIV warm line, which is the University of California, San Francisco warm line, which is an HIV consultation service. You can always you always reach another physician on the other end, usually an infectious disease person, who can help you with individual cases for moving forward with management, designing alternative treatment regimens, or any clinical question you may have in terms of management, and they are truly wonderful. I think Dr. Rosado will touch on post-exposure prophylaxis, but if you have questions related to needle stick problems, et cetera, in your clinic, this is also a very useful 1-888 number to contact to get advice about where to go next with needle stick injuries. Any questions around childbearing age women and HIV, or pregnant women who are infected? There is a perinatal hotline as well. So I would strongly recommend this clinician's consultation center if you have questions, and you can actually use this service in real time with your patient waiting in the room, because the response is very good. These guidelines below are those I was mentioning earlier in terms of primary care guidelines, and I will make sure anyone interested receives a copy of these resources for you to use in your own practices. So that's all I have. I think Dr. Rosado is here, and he'll be up shortly. It's very good. Self-explanatory.
Thank you for the invitation to come here and talk to you about HIV. That's what I do all day long at the University Hospital, and as you can tell, I am the Spanish-speaking doctor down there, so I follow the Spanish-speaking population. So we don't have too much time. There is a lot of things about HIV, some new stuff, but maybe you probably like to hear about post-exposure prophylaxis. If you had an accident, what we should do, and I think I might have good news for you. So, which way? Oh, got it. So we got about 1.1 million people in this country that is infected or are infected with HIV, AIDS, but also like 25% of those people don't know they have HIV. because we keep saying, well, there is these risk factors, men that have sex with men, IV drug use. And sometimes you talk to people in your clinic, in your office, and, you know, just human nature, they are not going to tell you some things just because they don't want to. They don't want you to know. It's important to know in big centers, in cities, San Francisco, New York, Miami, Baltimore, the HIV seroprevalence in patients that are in the hospital, it can be as high as 3.8%. Dr. Reese just completed a study 5 months at the emergency room at the University of Utah, and we tested people for HIV. And to our surprise, I don't remember the number, it was in the 300, 400 that people were tested, and all of them were negative. Maybe if we keep doing the study longer, we will find people who are HIV positive. And these are, obviously, we are testing people who don't know their HIV status. So just a minor thing about still in this country, males have a higher incidence of HIV compared to female. But as you can see, the female curve is going up a little bit. We don't want to see either going up, but unfortunately still, the incidence of HIV is not going down. That's the way we like to see it, obviously. African Americans lately have been a group that seems to be more affected. Obviously, it depends where you live. We don't have too many African Americans in this state, but if you go to other states, you will see that. And also Hispanic, the Hispanic population, they are having also a higher incidence of HIV infection. This is just to tell you that, you know, the cases of, this is AIDS cases, not HIV. After the introduction of 1996 highly active antiretroviral retroviral therapy, those cases have been going down, but then they plateau over here. Can't see this very well. Death also went down because we had now great therapy. So because of that, because the people are not dying, because we have excellent therapy for HIV, the prevalence, the people living with HIV keep increasing. This is good, obviously. We are now able to treat these people, and they are not dying. They are being healthy and working and doing everything else that they are supposed to. But also at the same time, we are having a bigger pool of people who are HIV positive, and that some of these people are not the best citizens of the world. And from that pool, we can continue having, new infections because some of these people continue to have unprotected sexual encounters or involving in high-risk behavior. Let's just keep that. So post-exposure prophylaxis. Okay. Okay. So we have about 400,000 healthcare workers in this country that, every year have some sort of occupational exposure, percutaneous injuries related to the work. The transmission of HIV by needle stick, that is a more common percutaneous exposure, is rare. It's about 0.3%. So keep that in consideration. This is percutaneous, so transmission by mucous membranes is much less. Look at that, 0.006%. So early studies that were done back in the 90s were using only ACT monotherapy. This is one of the oldest medications that we had to treat HIV. So keep that in mind too. The numbers that we have are based in ACT monotherapy. Many of these studies were done in animals, monkeys. Okay, and also it's important to know that in these animal studies, initiation of post-exposure prophylaxis should be done less than 24 hours after the incidence. And also it's important to know that if we are going to do this, we are supposed to complete 28 days of therapy. So those 2 points are important. Now, the less than 24 hours initiation of post-exposure prophylaxis is not like all the time we had to do that. Sometimes we are going to see people after 24 hours. We feel that after 72 hours, if somebody comes with a significant exposure, if you want to treat those people, that's fine, but you have to tell them that the chances that we are going to prevent HIV probably are not going to be optimal. Between 24 and 48 hours, I do that too, but after 72 hours, that is 3 days, is less likely. But if you encounter cases that somebody have been raped and happen that the perpetrator is HIV positive, I will treat this person anyway, but you have to educate the person and tell them, the chances of getting HIV. So the duration of treatment, and we will talk about that also, is an important thing in the prevention of this disease. So when they were doing the initial studies with ACT only, the transmissions decreased by almost 80%. So that's very good. We are talking about one single medication. So studies found that the risk factor for HIV transmission after this kind of incident is visible contaminated needles. And when we say contaminated needles, we mean blood, advanced HIV disease in the source patient, or early HIV disease. Back then, advanced HIV disease and early HIV disease, the common denominator in these two situations is that the HIV viral count is very, very high. And we know the higher the HIV viral count, the chances of spreading HIV increase. So the CDC recommend 2 or 3 drugs for prophylaxis after a significant exposure. We don't recommend one drug anymore, so also it's important to remember. But the main thing that I want to talk is about, is 2 or 3 drugs equal, or 3 drugs is better than 2 drugs? Well, we know that if you use 3 drugs, you had a higher incidence of side effects. And I mentioned to you earlier that if you're going to do that, the patient should take this medication for 28 days. So you don't want to give a medication to somebody that after 1 or 2 weeks say, I don't want to take it because I am having nausea, vomiting, I'm not feeling well. So it's important. So there is no published data in regard to which one is more effective, a two drug prophylaxis versus 3 drugs, because at this point we cannot do studies about these things. They probably are unethical. But we do a lot use a 3-drug post-exposure prophylaxis, not only us in North America, but also in the European countries. The premature discontinuation of this prophylaxis is an important issue. Why the effectiveness of 3 drugs is not maybe as good as 2 or 1 drug, just because people cannot take it for 28 days. So even though we don't know, people seem to use 3 drugs more than 2 drugs. The goal, obviously, of prevention is to prevent the HIV from establishing an infection in the lymph nodes. Remember, ACT monotherapy is excellent, almost 80%, early studies in people and animals. And shorter treatment duration is an important cause of post-exposure prophylaxis failure. So the CDC, the Center of Disease Control, recommend 3 drugs in this kind of situation. When there is a deep penetrating stick with a hollow bore needle involving patient that had high levels of circulating virus. It's great to say. Sometimes you don't have any idea if the source patient have a high HIV viral count or not, if the patient is taking medication. But usually this kind of situation happen in the hospital, and hopefully we will know the patient, and if the patient is HIV positive, and the patient is taking medication and that kind of thing. A 3-drug regimen have been associated with more side effects. And we are talking about nausea, vomiting, fatigue, headaches, and diarrhea. Those are probably the most common one. But also serious side effects like hepatic toxicity and hepatic failure, especially with nevirapine, that is Viramune, that's the other name. So we never use Viramune or nevirapine for post-exposure prophylaxis. And also, a non-adherence to the 3-drug regimen is a common problem. The other important thing to mention is the antiretroviral resistant rates among HIV-infected patients is increasing. Remember, we have more people that are infected with HIV that are living longer because they are taking medication. The more people in treatment, we had a lot of people that are non-compliant, so they are going to develop resistance to the medication. So that's an issue. because if the source patient have resistance, you need to know that so you can give the post-exposure prophylaxis regimen, the right one, to the person that have been exposed to that. Because if you give medication that happen that the virus is resistant, it's not going to do anything. We don't have this kind of resistance around here, but around the country it's about 12% for one drug, and in San Francisco it's 25%. So there is documented cases of post-exposure prophylaxis failure just because the drug resistant that we didn't know when the patient was given the regimen. So general recommendation. So the HIV post-exposure prophylaxis studies have been shown that ACT monotherapy can decrease transmission by 80% if you do it before 24 hours, and also if the patient complete the regimen for 28 days. There is not really data about 2 or 3 drugs, but knowing that the way we treat patients now is 3 drugs of different kind, then it makes sense that probably 2 drugs or 3 drugs might be more effective than monotherapy. Also, especially ACT is a medication that have been using from day one in this country to treat HIV. The chances of ACT resistant actually is higher too. So maybe we like to use something else. So the 2-drug post-exposure prophylaxis is probably the better choice after you get exposed to HIV in many situations. 2 drugs are effective, they are better tolerated, and the completion of 28 days is better if you use 2 drugs compared to 3 drugs. Remember that the prevalence of drug resistance is about higher than 15%, so you should do a 3-drug prophylaxis. So again, we don't have data in the state of Utah, and obviously if that is going to happen, it's going to happen here. But probably we don't think that we have a resistance rate of 15%. It's probably less than that. Although we get patients that they got infected with HIV in San Francisco and in other places where the resistance is higher. Every time we get a new patient, newly infected, a new diagnosis, we do an HIV genotype, and that test gives the information if the patient had already baseline resistance or not. So remember, the goal of post-exposure prophylaxis should be complete, to complete that in 28 days if you decide that the patient needs that, and start the medication as soon as possible after the exposure. And remember, a delay of more than 72 hours before the initiation probably means that this is not going to work. These are just graphs about that. Let's just keep moving on because there is something else. There is these resources that you can find at the CDC website. And we also have for, if you are somewhere that you don't have access to ask somebody about prevention of mother to child, you can also call and find out that information. And you can call us at the University of Utah Infectious Diseases Clinic, and we can help you if you had any questions about that. What about testing? That's another important thing, because now there is new recommendation about HIV testing in this country. So the goal of doing HIV testing, obviously, is to find those people who have HIV, but they don't have any clue that that is the case. Remember, I mentioned to you that about 1.1 million people in this country probably are infected, and 250,000 don't have any idea they are infected, because they don't feel, I don't have sex with unless, a guy. I don't have sex with another guy. I don't do drugs and that kind of thing. So we need to identify those people. They probably are a big source of persistent transmission because they don't know they had HIV. Early diagnosis and treatment provides a great benefit for this patient. There have been studies. There was one recently in the New England Journal that actually we had some guidelines about when to start treatment in HIV patients. Now this study, it's a study only, shows that if we start earlier, the chances that this patient is going to be alive for a longer time is much better. Not only that, but also healthy. They're going to be living longer and healthy life. The risk-based screening, that's when do you have sex with another man? Do you use drugs? Are you doing, having many girlfriends and not using condoms and that kind of thing? Usually fail to identify 100% of the people that might be infected. Okay? And also, when we check people that tested positive, about 25% report no high-risk behavior. So that's an important thing. So now we like to do, and hopefully many of you after this talk will start doing that, this opt-out screening, meaning that you're going to screen your patient, or you're going to say, we are going to screen you, we are going to do an HIV test. Do you want it or not? And you don't ask permission. You're going to say, we are going to do an HIV test. That's part of the test that we do. If the patient say no, then you don't do it. And also now the CDC and the federal government, but also state government, and I don't remember what are the rules here, we don't have to do any more pre-testing counseling unless the patient wants that. So you can spend some moment talking about that. But you don't have to. But I don't remember if Utah got over that or not. Many medical organizations obviously believe that this is the way to go in this country. That opt-out screening is cost-effective even when the HIV prevalence is low, like in this country that is less than 1%. Remember that I mentioned there is a lot of people that are infected with HIV, but 25% are aware that they have that. About people that are between 25 and 44 years old, the largest proportion of new HIV diagnosis, that was in 2006, and probably still the same thing. We still do the same thing that we used to do. There is a standard ELISA, and if the ELISA is positive, we are going to do a Western blot for confirmation. Okay? The sensitivity and specificity is excellent. So remember, individualized assessment of risk factor for HIV infection, a screening where a patient presents in a high prevalence or high risk clinical setting. So high risk patient, again, MSM, men that have sex with men, multiple unprotected sexual encounter. So because you are not MSM, but you have multiple unprotected heterosexual encounter, that also means that you are high risk. If you use drugs, doesn't matter, you are not using now, but you used when you were in college. IV drugs abuse. Exchange sex for money or drugs. Maybe you never done drugs, you never done anything wrong, but your boyfriend or girlfriend used to do that. And maybe you had this partner many years ago and you don't have any idea. And if you receive blood transfusion between 1978 and 1985. Now, high-risk settings are STD clinic, correctional facilities, homeless shelter, TB clinic that care for MSM, adolescents with high prevalence of STD, and clinics that deal with IV drug use, like a methadone place or something like that. So we recommend testing that opt-out screening test for high-risk patients. We mentioned which one are those. High-risk setting, migrant from high-prevalence country. We are pregnancy. Everybody who is pregnant should have an HIV test. That should be a routine thing now. And everybody between ages 13 and 64 that are sexually active. Basically everybody. Remember prevention, still abstinence, obviously. You don't have sex, you're not going to get anything. But monogamy is important. Condoms, there is female condoms now. There was a study about HSV associated with acquisition of HIV, especially in developing countries. But the study shows that the epidemiology shows that. But if you treat people for HSV in this country, they have a lot of studies. Actually, that doesn't prevent people from getting HIV. We do know that HIV treatment is prophylaxis. Remember, I mentioned to you, if you had a high viral count, then it's easier for you to spread HIV. With treatment, your HIV count is very low, so even if you had unprotected sex, the chances of spreading HIV is going to decrease. Spermicides that have been disappointed, actually some of these spermicides make HIV transmission easy. Post-exposure prophylaxis or pre-exposure prophylaxis. Obviously the breastfeeding issue that in this country, mothers that are HIV infected after they had a baby, they are not supposed to. And the vaccines have been disappointed also. The latest study by a vaccine by Merck, the pharmaceutical company, actually shows that their vaccine, people who received the vaccine during the study got more HIV than people who didn't get the vaccine. And maybe I should stop here because we had to have some time for questions. 8 minutes, okay. So let's just stop. Thank you very much. And Dr. Gregoire, you want to come here? They're going to ask you a question too. I just mentioned that just 3 important studies that came from Africa found that in in areas where HIV is very prevalent, circumcision, if the male is circumcised, it can decrease the acquisition of HIV by 60%. This is heterosexual sex, and we are talking about male, obviously. If the wife is infected and he's not, and he's circumcised, circumcision is a way to go in high prevalence area like Africa and other countries. Any question? Well, in Utah, we don't have a high incidence of of tuberculosis in the HIV population. We do see a lot, at least I can talk about the university hospital, a lot of the people coming from areas that tuberculosis is more endemic, then we see that. We have some African people with HIV, with tuberculosis, Hispanic too, but otherwise that will be the most important thing. Now, recently, we saw a patient, an American patient from here, that actually developed tuberculosis of the brain and pulmonary. So we had to keep our eyes open because we don't have to, hopefully we are not going to focus only on migrants, but it can happen with anybody still, tuberculosis. And tuberculosis and HIV, tuberculosis can happen if your CD4 count is high or low. Anybody can get tuberculosis. Any more questions? There have been some studies from here, observational studies, and in Europe, and actually some people are saying, and there was one in Sweden, that they felt that people, if you are diagnosed with HIV and now when you start treatment, you can be living for 25 to 30 years. Now, that is important to know that it's not like, you need to be compliant, you need to continue coming to the doctor to be sure that these medications don't cause any problem, because some of the medications are great, but there is some side effects that can happen later on.
And maybe part of the answer to that question is we don't know, because we know people that are extremely adherent, compliant with their medications day-to-day basis. Many are still alive. I was just talking with Dr. Johnson about the case of Magic Johnson, who was infected, I think, in the mid or late 80s, still going strong. No reason to think that he may not live a normal lifespan, barring any problems or toxicities of long-term medication. So I think the answer is still out there.
Long-term continued therapy?
Correct. Lifelong.
Well, there have been some studies too about that issue. I mean, how much money we are going to spend to keep somebody alive for a disease that we cannot cure. I don't have any data because I didn't think about bringing that, but actually the study shows that treating HIV, it might be more economic than treating somebody that had chronic heart problem or undergone dialysis or even cancer treatment. So it's cost effective, obviously. Just think about in the 80s how many people were very sick with very uncommon opportunistic infections and malignancy, how much you had to pay to take care of this patient in the hospital or in the clinic. Right now, if you do well with this medication, that's the only thing you need to take, HIV medication and no more. So it is cost effective. These people can work, they can go back to their normal life, and I think that's important too.
Yeah, the hospitalization savings must be incredible by itself, in the billions of dollars, obviously. When I was training, or was a medical student in the late 80s in New York, I would say, I don't have probably real accurate numbers, but probably 2 out of 5 patients, about 40% of inpatients at that time were HIV infected, and there for a long time in high-cost units. So the savings just with the advent of heart therapy has got to be tremendous.
They do, yeah. Private insurance company pay for HIV care, Medicaid, Medicare. I will say it depends on the regimen. I just showing you there all the medications that we have. and it can be less than 1,000 to maybe 2,000, but it depends on the medications that you're using and how many. There is some patients that require more medication than others.
What about the issue of breastfeeding in first world countries where other options like formula may not be available?
So the latest information about that is they did another study. They have been doing studies about breastfeeding and HIV transmission. The recommendations now are that the baby should be breastfed for the first 6 months of life. And after that, the mother had to wean and use formula. They did a study where babies were not breastfed since birth, only formula, and mothers that breastfed the baby for 6 months and then went to formula. Actually, what they found that in the first 6 months, if you didn't breastfeed the baby, the mortality was higher because they died secondary to diarrheal diseases or gastrointestinal condition. So they know that that's very important. The only important thing they found was that the transmission of HIV didn't really change too much in the first 6 months between the one who did and the one who didn't. Now, after 6 months, if you keep breastfeeding your baby, then the transmission of HIV starts going up, and there is a difference. So that was really interesting, and they cannot figure out what is the logic behind why the first 6 months and nothing after that. I mean, more after that. So. No, not really. So that's important. If you get blood on your hands or your arms and you don't have any inflammation of that area, any cuts, nothing, you just wash it with water and soap. You don't have to use Clorox or boric acid or whatever, and that will be okay. Now, if you had an open cut or an open sore or an inflammatory condition of the skin, it might be important. Remember, body fluids that do not have blood, probably they are not contagious. We are talking about not blood. I have some policemen calling me, the inmate spit in my eye. That is not really important. Nothing is going to happen unless there is blood in the saliva, visible blood. The same thing with tears, sweat, and even diarrhea. You have feces, but there is no blood on in the feces, then the chances of HIV transmissions are very, very low, and we don't indeed recommend prophylaxis with that kind of situation unless the patient gets very anxious and wants to take something. Now, in that case, if you feel that there is no need to prophylaxis, but the person wants prophylaxis, please use 2 drugs. Don't go with the 3 drugs.
I'd like to thank Dr. Gregoire and Dr. Rosado-Santos for an enlightening lecture and discussion on this very interesting disease that many of us have seen from its inception up to the status or the circumstance that it is now. We will adjourn this session. Lunch is in the I don't know what ballroom it's called, A or B or something, around the corner where we had breakfast. And the speaker there will be John Berry on the great influenza.